Hello, Sabaidi. Welcome to topic 6.3, Observational Study Design and Planning. I'm going to ask you to bear with me through this particular topic. It is the longest topic in the module, and I will work my way through it as quickly as possible. The learning objectives for this topic are that by the end of the topic, we hope you'll be able to distinguish analytic from descriptive study designs, identify observational study designs and when they are best used in research, and be able to begin the foundations of planning an observational study, including choosing the best study design for your goal, establishing analytic methods and plan, selecting the appropriate measures, and controlling for bias in both your planning and analysis. Again, some of these steps won't be fully covered until future topics and modules, but you can begin to move forward with your planning. I'd like to quickly cover the basics of analytic epidemiology, of which the goal is to identify and quantify relationships between an exposure and outcome. I'll use these symbols throughout this module to refer to the exposure, the blue circle with the letter E, which we can also call the risk factor, behavior, or independent variable, and the square with the letter O for outcome, disease, condition, event, or dependent variable. We first identify a relationship like cigarette smoking, the exposure, is associated with lung cancer, the outcome. I will use smoking and lung cancer frequently in this module because they're easy to understand and quantify, and there's a well-established relationship in the literature. We can then quantify the relationship. Smoking more than 50 cigarettes a day is associated with a 27 times greater odds of lung cancer than smoking 0 cigarettes a day. In order to assess these relationships, we need to have at least two groups, one of which is a comparison group. In this case, we're comparing lung cancer risk among the exposed, smokers, and the unexposed, those who do not smoke cigarettes. We can follow groups of smokers, exposed, and non-smokers, unexposed, over time to see if there are differences between these groups in who develops lung cancer. We typically use these comparison groups to build a study in which we can evaluate the differences in outcomes by exposure groups or the differences in exposure by disease groups. This 2x2 table is the fundamental table we create in epidemiology to understand whether an association exists between an exposure and an outcome. Returning to our study design figure, when we're ready for an observational study design, we will have some understanding of the patterns of our exposure or outcome of interest, and we should be ready to explore or test hypotheses regarding the outcome and exposure of interest. The next question we ask is, will the researcher assign the exposure to participants? If the answer is no, we're going to do an observational study. We've already addressed cross-sectional studies, so we'll focus in this topic on case control and cohort studies. This slide reminds you where observational study designs rank in terms of internal validity or the extent to which we can believe our study results. Cohort studies have more internal validity than case control studies. Returning to our strength of evidence pyramid, we see again that case control and cohort studies contribute great evidence to the literature. This quote by Cochrane in 1965 essentially means that we use observational studies to look at the cause and effect relationships among exposures and outcomes when it isn't appropriate or feasible for us to assign exposure or randomize individuals to different groups. In observational studies, People are divided into groups based on the presence or absence of an exposure or based on the presence or absence of a disease. And then we observe the exposure and disease over time, letting nature take her course. Typically, participants don't choose their exposure or outcome group. They happen to be exposed to the exposure or engage in the behavior or risk or to have the condition. This is what differentiates observational studies from experiments in which individuals are randomized into exposures or treatments. Examples of observational study designs include longitudinal cohort studies, which are prospective or towards the future, retrospective cohort studies, which look backward, and case control or comparative studies. In cohort studies, exposed and unexposed subjects are identified and followed over time to see if they develop some disease or condition. We start with the exposure known. Case control studies compare characteristics, including exposure, between two groups based on the presence or absence of a condition or disease. We start with the disease known and look for exposures. Observational studies watch the exposed over time and let nature take its course, which is why they're often called natural experiments. The first type of observational study we're going to address is the cohort study. There are two types of cohort studies. Prospective cohort, or follow-up studies, start with subjects of different levels of exposure, usually unexposed and exposed, but could be other levels, and follows them until either the outcome of interest occurs or the study ends. Exposure may or may not have occurred at the time the study starts, but everyone in the study does not have the outcome of interest or the disease. In retrospective cohort studies, we look back in time using historical data to make comparisons based on exposures or risk factors that occurred prior to the outcome of interest. Both the exposure and outcome have already occurred at the time of the study start. Cohort studies have the greatest internal validity second to experiments, but it's important to realize that a randomized control trial, or most experiments, are actually a prospective cohort study, but the fact that the researcher assigns the exposure to the individuals differentiates it from a standard cohort study and elevates the internal validity. This is a representation of a cohort design in which we begin with the exposure groups, those who have the exposure and those who do not, and follow time into the future until the outcome occurs or the study ends. Then determine if there are differences in the occurrence of the outcome by exposed and unexposed groups. In cohort studies, the participants are healthy at baseline, meaning that they do not have the outcome or disease of interest. There is no assignment to exposure or treatment. The participants have naturally been exposed or have engaged in the behavior or risk factor. Cohort studies can begin to establish a causal link between exposure and disease outcome with follow-up time. New cases of a disease are counted, so we are able to assess incidence or risk. You may also hear cohort studies referred to as panel studies, longitudinal studies, and prospective observational studies. This is another representation of the cohort design, starting with a sample of the population, determining who is eligible, dividing the eligible participants into exposed and unexposed groups, and then observing the outcomes. In a prospective cohort design, we begin with the disease-free population, in this example, people without lung cancer, divide our cohort into exposed and unexposed, smokers and non-smokers, and then follow the groups over time and count the cases of lung cancer in both the unexposed and exposed groups, or smokers and non-smokers. In a retrospective cohort design, a researcher selects a cohort and uses medical and other historical records to classify the sample into exposed and unexposed groups, again here smokers and non-smokers, and then determines whether they have developed the outcome. Typically, the exposure and outcome have already occurred, but the design works the same as a prospective cohort in that you begin with the exposure groups and then determine who developed the outcome. These are the broad steps to planning a cohort study and the bias that may be introduced at each step. You need to choose who will make up your cohort and how you'll assemble it. Determine how to measure the exposure and outcome and make sure the cohort is outcome-free at the start. Determine what covariates you'll collect. Plan methods for recruitment and follow-up. Establish standards and train rigorously to obtain the best data possible. How do we assemble a cohort? Identify those who are at risk or have experienced an exposure. Cohort studies are great for rare exposures, such as occupational or natural exposures. Make sure to exclude those with prior disease that may be related to the outcome or exposure. You can also identify those not likely to be lost to follow-up. Often, this is done by selecting a cohort from a specific group, like an automobile workers union or nurses or a specific community. Identify those who are able to provide valid and reliable information or with routine data that are available to access. Nurses' Health Study was formed to study women, and the investigators believed that nurses would be reliable at reporting health characteristics. Health insurance organizations are another example because they have detailed data on members. Next, you need to measure exposure accurately and consistently. This can be done using medical records, self-report, but you should have an objective measure of the exposure in order to make sure that you're classifying people correctly into the exposed and unexposed categories. The unexposed should ideally be representative of the eligible population from which you drew the exposed subjects. For example, if you're building a cohort of minors, you may select unexposed persons who live in the same communities and are the same age, perhaps the same gender as your minors, but have a different occupation. Loss to follow-up is the primary concern and cause of bias in cohort studies. When this loss is different between the exposed and unexposed, for example, more of the exposed drop out of the study, this will introduce bias and may affect your results. You need to determine how often and for how long follow-up will occur and should consider the length of time it takes for the exposed to develop the outcome. Follow-up can be very, very difficult. You'll need to plan and implement multiple ways of keeping and maintaining contact information for participants and should obtain contact information for the next of kin as well. You can use national indices or data to keep contact information current, and it is good practice to send communication often enough to help the participants feel that they are part of something important and that they are cared for or belong. Thank you notes, birthday cards, holiday cards, regular gifts or incentives branded with a study logo, reminders before data collection, or a regular newsletter are all good ideas to establish a bond between the participant and the study. What are examples specific to Laos that you could use or have used in your studies? Do you use databases such as vehicle registration or a death index or your postal service? What are some of your examples? Other types of selection bias of concern in cohort studies That is, any systematic error that arises from the procedures used to select study participants and from factors that influence participation. Those who volunteer to be part of a study or those selected from an occupational group may be healthier than the general population. If you exclude potential participants because of cost, distance, or other factors, you may bias your sample. In this bias, the concern is that the relationship between the exposure and disease may be different in the sample than among the population. One of the most important ways to reduce bias in planning and implementing a cohort study, and really any study, is by establishing written, step-by-step protocols and training all study staff to understand and follow those protocols in every situation. Using standard tools for measurement and data collection, standard definitions of exposure and outcome, objective markers of the exposure when you can, such as blood tests, and blinding your data collection staff to whether the participants are in the exposed or unexposed groups can greatly reduce the opportunity for error. In addition, measuring differences between those who drop out and those who do not can not only help you later in analysis, but might identify reasons for dropout that you have control over as the investigator and could change. We mentioned the ways to improve your follow-up and create a feeling of belonging, but also making sure that you are not overburdening your participants with lengthy surveys or too frequent visits, and/or are providing adequate or better than adequate compensation to send a message to your participants that their participation in the study is important, because it is. These are a few ideas to help reduce bias, and we'll address bias more in topic 6.5. In cohort studies, we can measure new or incident cases of the disease or outcome, so we are measuring risk. The measures of frequency we use are cumulative incidence for fixed cohort studies, where everyone is disease-free at the beginning and is followed for the same amount of time, and incidence density, which is used for dynamic cohorts when subjects may enter or leave the study and contribute the amount of time they were in the study to the denominator. For today, we're only going to focus on cumulative incidence and relative risk. First, we can calculate the cumulative incidence among the exposed, which is the outcome, yes, A, over the total number of people who are exposed. We then calculate the cumulative incidence of the unexposed group, or that is the number of the people with the outcome, C, over the total number of unexposed. And this assumes that there is follow-up time so that these incident cases are risk. Relative risk is an estimate of the risk of developing the disease in the exposed group relative to those who are not exposed. It measures the strength of the exposure-disease relationship. We take the cumulative incidence of the exposed and divide it by the cumulative incidence in the unexposed to get the relative risk. The null hypothesis for relative risk is that the relative risk is equal to 1, or there is no difference between the incidence risk of disease in the exposed and unexposed. The alternative hypothesis is that there is a difference in risk of disease in the exposed and the unexposed. Relative risks greater than 1 indicate a positive association, or an increased risk of developing the disease among the exposed. Relative risks less than 1 indicate an inverse association, or a decreased risk of developing the disease among the exposed relative to the unexposed. The best way to interpret this is to say the risk of disease in the exposed groups was whatever the value of the relative risk, times greater or lower than the risk of disease in the unexposed group. You can also express it as a percent, but know that a relative risk of 2.5 means that the risk in group A is 150% higher than the risk in group B. It can get tricky. There are several ways to control for bias in a cohort study in the analysis. We'll talk more about these in Module 7, but a few ways are to do matching, in which subjects in the exposed group are matched to subjects in the unexposed group. Multivariate analysis for a binary outcome, which is expected, and you can use propensity scores to address confounding through matching, stratification, covariate adjustment, and treatment weighting. These next few slides provide a summary of the steps in the process of planning your cohort study, where you can reduce bias, and in statistical planning and analysis. Cohort studies are expensive to plan and implement and to maintain follow-up, particularly for long-term studies. They can take a very long time to conduct, depending on the latency period between exposure and outcome, but they are efficient in that you can assess multiple exposures and outcomes in one study and both generate and test hypotheses. It is not efficient for rare disease outcomes, however. You don't want to wait 30 or more years for smokers to develop lung cancer. Cohorts allow for fairly strong internal and external validity. And here is a reference of some of the advantages and limitations of a cohort study. Two examples of long-standing cohorts are the Framingham Heart Study, which was started in 1948 in the town of Framingham, Massachusetts in the United States, and has continued to follow 2 generations of original participants, as well as broadened to include more diverse participants. The careful approach to keeping contact information for follow-up in the Framingham Heart Study actually resulted in a set of studies on the social network contacts of Framingham Heart Study participants. The Nurses' Health Study began in 1976 as a cohort of women that would be easier to follow and would have reliable reporting on health changes. It is now in its 3rd generation of participants. Are there any longitudinal cohort studies that are established in Lao PDR? Cohorts do not have to span decades. They can be done in shorter periods of time, but they are expensive to establish, so it is a worthwhile investment to continue the research for as long as possible. The second type of observational study we'll talk about today is the case control study. Here it is in our ranking of validity, lower than the cohort studies, but higher than a cross-sectional in observational studies, and in how it contributes to the field of evidence. In a case control study, we start with the outcome of interest, including cases with the disease or outcome and a similar group of controls who do not have the outcome. And then we look back to see what exposures we might find that differ between cases and controls. Case control studies are retrospective, and that they begin with the outcome and look into the past to investigate possible exposures for the disease. They are best used in several ways. First, for diseases in the early stages of etiology, where we don't yet know the causes or development of the disease. We have the cases, and we can look back into the past of the cases to find exposures, and then proceed with a more complex or expensive study design for more information. They are also used for rare diseases, where we would need an incredibly large cohort to have enough people to ever see the disease arise, or for diseases with long latency periods, like, as I mentioned before, cigarette smoking and lung cancer, so you don't have to wait that 30 years for the cancer to develop. They're more cost-effective for these types of diseases. You can also study multiple exposures associated with a single disease. Here's a representation of the case control study design in which you sample your population, identify the cases with disease and the controls who do not have the disease, and then look back in time to see whether the exposure occurred among cases and controls. Here's another representation if you'd like to see study designs in this format, taking the eligible population, separating them into cases with the disease, and identifying controls without the disease, and then of those who choose to participate, dividing them into groups of exposed and unexposed. How do we select cases? There are a variety of sources for identifying cases, including patients in hospitals, clinics, practices, or through disease registries like national cancer registries. We usually consider incident cases of a disease and set a limit to how long ago they would have been diagnosed, as this reduces some possible bias due to survival time. Think carefully about how cases are selected so that the process doesn't introduce bias. What if all the patients' cases are from the same hospital or are seen by the same physician? What bias could occur if that were the case? An issue of concern is if there is differential selection bias, in that cases are unintentionally selected because of some kind of tie to the exposure status. Controls should ideally be selected from the same population as cases to reduce control selection bias. They may be non-hospitalized persons living in the same communities, siblings, co-workers. There are many ways to select controls, but you must find a group of people who adequately reflect the exposure level in the target population. Matching is a way of selecting controls so that they are similar to cases, and this minimizes confounding by making the groups as similar as possible except for the outcome. You can do this by selecting controls that match individual cases on matching factors, or by matching the proportion of controls with some set of factors with a proportion of cases with those factors. If you introduce matching, you do have to do a matched analysis. As in the cohort study, you need to have standard definitions for exposure and outcome, standard tools for data collection, and objective markers of exposure if possible. These are usually derived from medical record and data extraction or by observation or self-report, so training observers or interviewers to obtain data in the same manner is very important. Again, blinding can help reduce this bias. Recall bias occurs when cases are more or less likely than controls to recall and report prior exposures. This is a real concern, given that people with a disease may be more likely than those without a disease to have thought about the exposures or risk factors in their past in trying to understand why they have the disease. So again, we can get differential misclassification when we classify exposure wrong among cases and controls differently. Temporality in case control studies is weaker than in a cohort and reduces our ability to make causal associations. We cannot rule out reverse causality, where the disease is actually a cause of the exposure. We don't measure new occurrence of a disease, so we can't estimate risk or probability, only odds. These slides walk us through the steps of planning a case control study and the bias associated with each. We must identify cases and select them carefully, identify representative controls, decide whether to use matching and what type, determine how best to measure variables, and carefully train our data collectors, and ensure adherence to study protocols and measurements. Because the data from case control studies are not as high quality as other studies, case control studies are more prone to bias, particularly information bias. The measures of disease association used in a case control study are the exposure odds ratio, and we use multivariate regression modeling in statistical analysis of case control studies. The null hypothesis of the case control study is that the exposure odds ratio is equal to 1, or there is no difference in the odds of exposure in the cases and in the controls. The alternative hypothesis is that there is a difference in odds of exposure between cases and controls. We take the odds of exposure in cases, which is A over C, and the odds of exposure in controls, which is B over D, and then we can create an odds ratio for exposure by comparing odds that a case was exposed to odds that a control was exposed. In interpreting the exposure odds ratio, we say the odds of exposure in the diseased or cases group were value of the OR times greater or lower than the odds of exposure in the not diseased or control group. This is not risk, this is odds, so we don't use terms like risk or likely. There is also the opportunity to express the odds of a percent. Of course, in analyzing case control data, the exposure OR is only the crude measure of disease association, and we would use multivariate regression and other modeling to control for confounding in our results. Case control studies can be done pretty quickly and in timely response to a need, and they're fairly efficient. They can measure multiple exposures and are the best choice for rare outcomes and diseases. They make a fairly strong contribution to the evidence in literature, and while internal validity can be compromised by data quality, training and objective measurement can improve this. We return to our cigarette smoking and lung cancer example, for which a case control study is actually the ideal study design. In this study, from the general population, they selected hospital patients who were younger than 75 years of age, and they split those into cases of lung cancer patients and controls who were patients but without lung cancer. Of those who agreed to participate, they then grouped them by smoking and no smoking as the exposure in both the cases and controls groups. The original study linking cigarette smoking and lung cancer was a case control study published in the British Medical Journal in 1952. They looked at those lung cancer patients and control patients and measured current and past cigarette smoking. You can see by the fact that only 68 patients of the 2,714 total patients in the study didn't smoke at all, that everyone was a smoker in 1952. In this study, they found that the odds of cigarette smoking in lung cancer patients were 9.1 times greater than the odds of cigarette smoking in control patients who did not have lung cancer. In cohort studies, we look at disease across exposure groups. So we move from the left, exposed and not exposed, across to the right. And in case control studies, we look at exposure among cases and controls. So we move from the top to the bottom. Finally, bias in observational studies can be adjusted in analysis with matched sampling, stratification, and model-based adjustments, such as propensity scores. But we'll discuss these more in Module 7. Finally, observational study designs are studies in which we group people on the presence or absence of an exposure or based on the presence or absence of a disease. And we observe the exposure and disease over time, letting nature take its course. There are many opportunities for bias that can be reduced with careful planning and analysis, and they contribute strong evidence to the literature. Thank you. And there are references on this final slide.